Welcome to ClinMed Compass, your path to medical excellence. I am Dr. Emorinken, and in today's lecture, we'll be taking a detailed look at meningitis, a clinical overview. This session is part of the ClinMed Compass lecture series, where we simplify key internal medicine topics for medical students, residents, and all lovers of clinical medicine. If you are passionate about mastering clinical medicine, don't forget to subscribe and turn on the notification bell so you never miss any of our updates. Now, grab your notepad and let's dive in. So, what exactly is meningitis? Meningitis is the inflammation of the leptomeninges, that is the arachnoid and the pia mater, and the subarachnoid space. This inflammation can be infectious, caused by bacteria, viruses, fungi, or parasites, or non-infectious, triggered by autoimmune disorders, medications, or malignancies. Clinically, it presents with meningeal irritation, abnormal cerebrospinal fluid, and often neurological dysfunction. Meningitis is a medical emergency. Therefore, delayed treatment can lead to devastating outcomes. And who is most at risk of meningitis? Neonates, children under 5, the elderly, and anyone immunocompromised, whether from HIV, chemotherapy, or chronic illnesses. Next, we'll take a look at the global burden of meningitis. Bacterial meningitis affects roughly 2.8 million people each year, with a 10 to 30% mortality rate, even with treatment. In Africa, we have the well-known meningitis belt, which stretches from Senegal to Ethiopia, spanning over 26 countries. Epidemics in this region are common, especially during the dry season, and is often due to Neisseria meningitidis. Viral meningitis is the most common form worldwide, usually self-limiting and benign, with enteroviruses responsible for over 85% of cases. Tuberculous meningitis remains a leading cause in adults in high-burden countries, while cryptococcal meningitis is a major killer among HIV-positive patients. Here is a visual of the meningitis belt in Africa. Stretches from Senegal, Gambia, Guinea-Bissau in the west, down to Mali, Burkina Faso, northern part of Nigeria, and stretches down to Ethiopia. These are high epidemic risk zones. During the dry season, from December to June, dust, low humidity, and crowded living conditions create a perfect storm for meningococcal outbreaks. If you practice in or travel to this region, vaccination and surveillance are non-negotiable. Let's move on to the anatomy of the meninges. The meninges are the protective layers surrounding the brain and the spinal cord. They consist of 3 main coverings: the dura mater, which is the tough outermost layer adhering to the skull; the arachnoid mater, which is the thin middle layer responsible for cerebrospinal fluid reabsorption; and the pia mater, which is the delicate inner layer that closely adheres to the brain surface, providing nourishment. Between the arachnoid and the pia mater lies the subarachnoid space, which contains the cerebrospinal fluid. Understanding these layers is key, because inflammation of these membranes and the subarachnoid space is what defines meningitis. This is a cross-sectional diagram showing the meninges. Starting from outside, you have the skin, the bone. This is the dura mater, the arachnoid mater, and the pia mater, which closely hugs the brain. Notice also the arachnoid granulation, that these are projections that help to reabsorb the CSF into the dura sinuses. Now, let us briefly review the cerebrospinal fluid. The cerebrospinal fluid is produced by the choroid plexus in the lateral, third, and fourth ventricles at a rate of about 500 milliliters per day. The total CSF volume is around 150 milliliters. Its major functions are to cushion and protect the brain and the spinal cord, to remove metabolic waste products, and to maintain chemical stability and intracranial pressure homeostasis. Follow the CSF flow pathway with me. It's produced in the lateral ventricles, flows through the foramen of Monro into the third ventricle, down the Sivian aqueduct into the fourth ventricle, exits via the foramen of Magendai and foramen of Luschka into the subarachnoid space. Finally, it's absorbed by the arachnoid villi into the venous sinuses. Any blockage, say from adhesions, will lead to hydrocephalus. The blood-brain barrier consists of tight junctions between endothelial cells that protects the brain by limiting the entry of harmful substances, toxins, and pathogens. In meningitis, inflammation causes breakdown of the blood-brain barrier, allowing proteins and white blood cells to enter the cerebrospinal fluid. This disruption contributes to cerebral edema and neurological dysfunction. Remember the difference between meningitis and encephalitis. Meningitis is the inflammation of the meninges. Encephalitis is the inflammation of the brain parenchyma. However, both of them can coexist as in meningoencephalitis. Now let's classify meningitis. We can classify meningitis in three ways: by etiology, by time course, and by the site of involvement. First, by etiology, that is, by the underlying cause. Meningitis can be infectious or non-infectious. Under infectious causes, we have bacterial, viral, fungal, tuberculous, and parasitic. These are caused by different organisms and often differ in severity and clinical course. Then we have the non-infectious, which include autoimmune conditions such as lupus, sarcoidosis, drug-induced reactions, and malignancy-related meningitis. Second is by time course. You have acute meningitis, which develops rapidly over hours to days and is usually bacterial or viral. You have subacute meningitis, which evolves more slowly over several days to weeks and is typically caused by tuberculosis or fungi. Then chronic meningitis, which persists for 4 weeks or more, often due to TB, fungal, or malignancy. And finally, by site of involvement into leptomeningitis. This involves the pia and the arachnoid matter, and this is the typical form of meningitis we encounter. Then we have the Parkhill meningitis, which affects the dura mater. It's rare, but may occur with tuberculosis, syphilis, or sarcoidosis. Let us go over the causes of meningitis in more detail. We talk about the infectious causes first. Number 1, bacteria. This is the most serious and contagious form. Common bacterial organisms implicated include Neisseria meningitidis, also referred to as the meningococcus, Streptococcus pneumoniae, pneumococcus, and Haemophilus influenza type B. Less common organisms are Listeria monocytogenes, Escherichia coli, Group B Streptococcus, and Staph aureus. The bacterial organisms can be distributed in terms of age groups and risk groups. For example, in neonates, common pathogens are E. coli, Listeria monocytogenes, group B streptococcus. In preschool children or infants, Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenza. In older children and adults less than 50 years, Streptococcus pneumoniae and Neisseria meningitidis. For adults greater than 50 years, Strep pneumoniae, Listeria, and some gram-negative bacilli. Then the immunocompromised, think of Cryptococcus neoformans, Mycobacterium tuberculosis, Listeria monocytogenes. For persons who have had surgery, neurosurgery, skull fracture, think of Staph aureus and Pseudomonas. Next is viral. They are more common and self-limiting and usually cause aseptic meningitis. The leading causes are enteroviruses. Example, Coxsackie, echovirus. Others include herpes simplex 2, which causes Mullaret's meningitis, that's the recurrent benign lymphocytic meningitis. Varicella zoster, mumps, influenza, Epstein-Barr virus, HIV, and West Nile virus. We have the fungal meningitis, which occurs mostly in the immunocompromised individuals. Important pathogens include Cryptococcus neoformans, Histoplasma, Candida, Aspergillus species, Blastomyces. Tuberculous meningitis. This is caused by Mycobacterium tuberculosis. It's typically chronic and severe. Then we have parasitic or protozoa. These are rare, often following freshwater exposure. Always think of Naegleria fowleri, which causes the primary amoebic meningoencephalitis. Don't forget the spirochetes like leptospirosis, Lyme disease, syphilis, and rickettsial organisms causing typhoid fever. These are uncommon, but think of them in the right clinical context, like travel history, tick exposure, or systemic clues. Then we have the non-infectious etiology. First, malignancy, what we refer to as carcinomatous meningitis. Breast malignancy, lung CA, lymphoma, leukemia, melanoma have been implicated. Autoimmune or inflammatory diseases like systemic lupus, erythematosus, sarcoidosis, Behçet's disease. Drugs like non-steroidal anti-inflammatory drugs, intravenous immunoglobulin, trimethoprim sulfamethoxazole, then intrathecal chemotherapy. Others like post-neurosurgery, chemical irritation have also been implicated. Briefly on the causes of aseptic meningitis. Aseptic meningitis in the sense that no bacteria is grown on standard culture and gram stain. It's important to know that the causes isn't always viral. So this table shows the full spectrum of the etiology of aseptic meningitis. The first is viral, enteroviruses, herpes simplex, varicella zoster, HIV mumps, atypical infections like TB, syphilis, Lyme disease, rickettsia, fungal like Cryptococcus, Coccidioides, Histoplasma, Aspergillus. Then we have miscellaneous infection like Toxoplasma, leptospirosis, Whipple's disease. Then non-infectious causes sarcoidosis, lupus, brain tumors, and drugs like trimethoprim sulfamethoxazole, NSAIDs. So aseptic doesn't mean harmless. It means you need a broader diagnostic lens because these organisms are not seen in standard gram stain and culture. Now let's highlight some of the risk factors. We have host-related factors such as age, the extremes of ages as in neonates, elderly, immune suppression, HIV, diabetes, malignancies, organ transplants, cranial defects, skull fracture, neurosurgical procedures, ventriculoperitoneal shunts, and close contact with infected persons. Environmental factors such as crowded living conditions as in dormitories, barracks, travel to endemic areas, especially areas endemic to meningococcal meningitis, and exposure to contaminated water. Organisms like Naegleria fowleri are implicated here. Then medical history factors, recent upper respiratory tract infection, otitis media, sinusitis, and lack of vaccination against H. influenza, strep pneumoniae, and Neisseria meningitidis. How do pathogens reach the meninges? The first route of spread is hematogenous spread. This is the most common. Bacteria like Meningococcus or Pneumococcus invade the bloodstream from the nasopharynx, then cross the blood-brain barrier. 2, it could be by direct contiguous spread from nearby infections like sinusitis or mastoiditis. This is common with H. influenza and strep pneumonia. Then by direct inoculation via trauma or surgery and passage of shunts, introducing organisms like Staph aureus and Pseudomonas. Congenital defects, CSF leak can allow mixed flora entry. Then retrograde neuronal spread. Viruses like herpes simplex virus or rabies travel along peripheral nerves into the central nervous system. Now let's discuss how meningitis develops. From the moment an organism enters the body to the point it causes neurological symptoms. It all begins with colonization. The infecting organism first settles in the nasopharyngeal mucosa or nearby surfaces. At this stage, there may be no symptom, but the bacteria have found their entry point. Next is invasion. From the nasopharynx, the pathogen enters the bloodstream, where it must evade immune defenses such as complement and antibodies. Once in circulation, it gains access to the central nervous system. Then comes the third step, which is the CNS entry. The organism crosses the blood-brain barrier, reaching the subarachnoid space. Here, the body's immune response is limited, giving the pathogen a chance to multiply freely. This triggers inflammation. Cytokines such as interleukin-1, tumor necrosis factor alpha, and interleukin-6 are released. These molecules increase the permeability of the blood-brain barrier, allowing leukocytes and protein to flood into the cerebrospinal fluid. As a result, pus forms, adhesions develop, and cranial nerves may become irritated and damaged. Next, we see the vascular effects. The inflammatory processes causes changes in the cerebrospinal fluid. The pressure increases, protein increases, the number of cells increases, and glucose is consumed based on the organism involved. Also, the processes can cause end arteritis, which is the inflammation of the small cerebral vessels, leading to infarction of the brain tissue. Adhesions around the ventricles may also obstruct the flow of the cerebrospinal fluid, producing hydrocephalus. Finally, all these changes contribute to raise intracranial pressure. Both vasogenic and cytotoxic cerebral edema occur, resulting in neuronal injury, ischemia, and cerebral dysfunction. Clinically, these processes explain the hallmark of features of meningitis, such as fever, headache, neck stiffness, seizures, altered consciousness, and focal neurologic deficits. Clinical features. The classic triad of meningitis is fever, headache, and neck stiffness. However, only half of patients present with all three, but 2 or more features occur in over 90% of cases. Other symptoms include altered mental status, nausea, vomiting, photophobia, seizures, focal neurologic deficits, cranial nerve palsies. A non-blanching petechia or purpuric rash suggests meningococcal infection. Special populations present atypically. For the neonates, may present with poor feeding, irritability, bulging frontal nail, hypotonia. For the elderly, they may present with confusion, lethargy. For the immunocompromised, presentation may be subtle or atypical. It is important to note that the triad of fever, headache, and neck stiffness may be absent in these groups, so don't wait for it. Physical signs. We'll start with the signs of meningeal irritation. The signs of meningeal irritation occur in less than 5% of patients with meningitis. They include the Kenny's sign. This is pain or resistance on knee extension with the hip flexed at 90 degrees. Brudzinski's sign. Passive neck flexion causes involuntary flexion of the hips and knees. Then the third is the jot accentuation maneuver. This is worsening of the headache when the head is rapidly rotated side to side, usually 2 to 3 rotations. It is important to state that the jot accentuation maneuver is actually more sensitive than the Kenny's and Brudzinski signs. Other physical signs in meningitis include papilledema, which is due to raised intracranial pressure, cranial nerve palsies, petechial rash, which indicates a meningococcal infection, and opisthotonous posturing in severe cases. This is the Kenny's sign, whereby you have pain or resistance occurring when extending the knees with the hips at 90 degrees. The pain and resistance are actually felt along the hamstring muscles. This is the Brudzinski sign, which is passive neck flexion causes involuntary flexion of the hips and the knee. Then this picture here demonstrates the non-blanching nature of the meningococcal rash. This table shows some clinical clues that can point to the cause of meningitis. So they are very important. For example, if there is petechial rash, you think that the positive cause may be meningococcal infection. For skull fracture, think Staph aureus. For ear disease, look at contiguous spread, possibly from a congenital lesion. Lymphadenopathy, dermatitis, candidiasis with uveitis, think of HIV infection. When the patient has rash or pleuritic pain, think of an enterovirus infection. Parotid swelling, mumps, history of occasional work in drains, canals, polluted water, or recreational swimming, think of leptospirosis. When the patient presents with vesicles, think of viral infections like herpes simplex or varicella zoster infection. Sore throat, jaundice, lymphadenopathy, think of infectious mononucleosis. Bleeding with red eye, you can also consider leptospirosis. Meningitis can spiral quickly. So we'll discuss the complication in two forms, acute complication and long-term complication. For the acute complication, we have cerebral edema, which can lead to herniation, seizures, syndrome of inappropriate ADH secretion, SIADH. This one will usually cause hyponatremia, septic shock, disseminated intravascular coagulopathy. They may also come down with venous sinus thrombosis. Cerebral infarction, cerebral abscess are acute complications. Then we have the Waterhouse-Friderichsen syndrome. This is actually a fulminant life-threatening complication of meningococcal septicemia, characterized by adrenal gland hemorrhage, shock, and disseminated intravascular coagulopathy. We look at the long-term complications, which are actually more in bacterial meningitis. They can have sensorineural hearing loss in up to 30% of patients, cognitive impairments, memory impairments, hydrocephalus, especially the communicating type, epilepsy in 5 to 10%, and focal neurological deficits. You may have cranial nerve palsies, hemiparesis. A thorough and systematic approach is essential. Diagnosis is based on clinical suspicion, laboratory tests, and CSF analysis. We'll start with the laboratory investigation. Complete blood count, show leukocytosis. Inflammatory markers like C-reactive protein and the erythrocyte sedimentation rate are usually elevated. It's important we obtain blood cultures even before starting antibiotics. We also assess the renal function, the liver function, serum glucose, and the coagulation profile. Chest X-ray may reveal pneumonia or TB as a possible source. HIV testing and TB screening should be considered in relevant setting. Prompt identification of systemic involvement helps guide targeted therapy in meningitis. Lumbar puncture and CSF analysis. CSF analysis remains the gold standard for confirming meningitis. Always collect the CSF for cytology, biochemistry, that's glucose and protein, and microbiology, gram stain and culture. Simultaneously, you obtain a serum glucose sample for comparison. The opening pressure and the appearance of the CSF is not left out. It's important for us to state that there are situations where you want to do an imaging before lumbar puncture, especially in raised intracranial pressure. Some of the conditions include altered sensorium, somebody having a GCF of less than 11, focal neurologic deficits, papilledema, recent seizure, age more than 60 years, recent neurosurgery, head injury, or intracranial mass lesion. However, do not delay antibiotic for CT scan or lumbar puncture. This is a summary table that helps us interpret typical CSF findings. You see the parameters we look at: the opening pressure, the appearance, presence of WBC count, predominant cells, protein, glucose, the microbiology, as well as other special tests. This is the normal findings in the CSF. You see that the glucose in CSF is 45 to 80 milligrams per deciliters, which is about a third of that of the serum glucose. In bacterial meningitis, the CSF usually shows that the opening pressure is elevated, the appearance of the CSF could be turbid or purulent, WBC count is severely elevated, and the predominant cell is the polymorphonuclear cells, which are the neutrophils. Protein is elevated, and the plasma and the glucose is reduced. The reason is bacteria actually consume glucose. So the glucose is usually less than 40 milligrams per dl, or half of plasma glucose. Then gram stain and culture is positive in considerable number of cases. For viral meningitis, the CSF usually remains clear, while the opening pressure is normal or mildly elevated. The WBC count is elevated, but not as that of the bacteria. Predominant lymphocytes, protein elevated, normal glucose, the virus, or they do not consume glucose. Then the typical gram stain and culture, you cannot use it to isolate viruses. So we can do viral PCR for herpes simplex and enteroviruses. For tuberculous meningitis, the opening pressure is elevated. They usually have a clear or cloudy appearance, and in most cases, they usually have this cobweb appearance. The WBC count is elevated with predominant lymphocytes. The protein, the glucose, the protein is elevated, the glucose is reduced, usually less than 40 or half of plasma glucose. You will do the acid alcohol fast bacilli or gene experts to be able to detect Mycobacterium tuberculosis, or you can assay for adenosine deaminase, also polymerase chain reaction. For fungal meningitis, the findings are elevated opening pressure. It's either clear or cloudy appearance. The BBC count is elevated. Predominant cells are lymphocytes also. Increase in protein and reduced glucose, usually less than 40 milligrams per deciliter or less than half or 50% of that of the plasma glucose. Microbiology here, we cannot use the usual gram stain and culture also to isolate fungus. So we do the India ink tests or the cryptococcal antigen tests. You may also culture and do polymerase chain reaction. The India ink test is for cryptococcal meningitis, also with the cryptococcal antigen tests. Now let's go over some clues in the CSF gram staining in meningitis. Gram-positive diplococci suggests Streptococcus pneumoniae. Gram-negative diplococci, Neisseria meningitidis. Gram-negative Coccobacilli, Haemophilus influenza. Gram-positive cocci in clusters, Staphylococcus aureus. Gram-positive rods or bacilli, Listeria monocytogenes. Even if no organism is seen on gram staining, remember that doesn't rule out bacterial meningitis. Gram stain sensitivity ranges between 60 to 90%. We'll now move on to discuss additional diagnostic tests we can do with the cerebrospinal fluid. The cytology of the CSF helps us to detect carcinomatous meningitis. We'll see malignant cells in the CSF. Latex agglutination test rapidly identifies bacterial antigen like that of strep pneumoniae or Neisseria meningitidis. Autoimmune and inflammatory markers such as angiotensin converting enzymes levels, anti-nuclear antibody, oligoclonal band. These ones help us to suspect non-infectious causes. For example, angiotensin converting enzyme, you think of sarcoidosis. Anti-nuclear antibody, you think of lupus. Then, other tests that can be done in meningitis, you have neuroimaging, CT scan or MRI. These ones are invaluable for detecting complications like abscess, hydrocephalus, or cerebral infarction. We have also stated previously that the CT scan or MRI can also be done before lumbar puncture if we think the patient has features suggestive of raising intracranial pressure. Now let's look at some conditions that may mimic meningitis. Encephalitis affects the brain parenchyma, unlike in meningitis where the meninges are involved. Also in encephalitis, they have more of behavioral manifestation. Brain abscess. This presents with focal neurological signs, and CT scan will be able to show an abscess also. Subarachnoid hemorrhage. This is characterized by sudden thunderclap headache. Cerebral malaria occurs especially in endemic areas. Tetanus, then severe sepsis with delirium. For tetanus, they can have local rigidity. They can have obstructionus posterior, which are also present in meningitis. A high index of suspicion and careful evaluation will help to differentiate these differentials from meningitis. Management of meningitis. The key principles are to stabilize the patient. You ensure airway, breathing, and circulation. You start empiric antibiotics immediately after cultures taking. Adjust therapy once results and sensitivities are available. Administer steroid like dexamethasone before or with the first antibiotic dose to reduce neurological sequelae, and provide supportive care like fluids, fever control, seizure control, measures to reduce raised intracranial pressure. Remember, intravenous antibiotics are the cornerstone of therapy in meningitis. This slide summarizes empiric antibiotic regimen by age group and risk. For neonates, ampicillin plus cefotaxime or gentamicin. Infants and children, ceftriaxone or cefotaxime, plus or minus vancomycin depending on the scenario. Adult under 50, ceftriaxone or cefotaxime with or without vancomycin. Adult over 50 years or immunocompromised, the same as adult less than 50, but this time around you want to add ampicillin to cover for Listeria monocytogenes. For persons who had neurosurgery, CSF shunts, penetrating head trauma with ceftazidime or meropenem plus vancomycin, because these help you to cover for Pseudomonas and Staph aureus. When culture is available, you tailor therapy based on culture and sensitivity. So this slide is actually showing us antibiotic therapy for specific bacterial pathogen. For example, N. meningitis, regimen or drug of choice is benzyl-penicillin. Alternative agents, cefuroxime, ampicillin, chloramphenicol. For Streptococcus pneumoniae, that is beta-lactam sensitive, you give cefotaxime or ceftriaxone. Alternative agent is chloramphenicol. For strep pneumoniae, it is beta-lactam resistance. It's the same as ceftriaxone, cefotaxime. Or this time around, you add vancomycin or rifampicin. Alternative agent, vancomycin plus rifampicin, moxifloxacin or gatifloxacin. For Haemophilus influenza, cefotaxime or ceftriaxone. Alternative, chloramphenicol. For Listeria monocytogenes, ampicillin plus gentamicin. Alternative, ampicillin plus cotrimoxazole. For Streptococcus suis, cefotaxime or ceftriaxone. The alternative agent, chloramphenicol. For the asterisk agents, it's given if we have beta-lactam anaphylaxis. Adjunctive or supportive measures. Dexamethasone, 10 milligrams intravenous every 6 hours for 4 days. This should be given before or with the first dose of antibiotics, especially in pneumococcal meningitis. It reduces hearing loss and neurologic sequelae. However, it does not reduce mortality. Fluids and electrolytes must be monitored closely. Antipyretics for fever, anticonvulsants to control seizures. Monitor head elevation, hyperventilation are all measures that have been used to manage raised intracranial pressure. Oxygen therapy for hypoxia, and ensure you treat complications promptly if they are present. How long do we treat bacterial meningitis? This depends on the pathogen that is involved. For Neisseria meningitidis, 5 to 7 days, because it runs a very rapid course. Haemophilus influenzae, 7 to 10 days. Streptococcus pneumoniae, 10 to 14 days. Listeria monocytogenes, 21 days. And if it's due to gram-negative bacilli like E. coli, you may also want to treat for 21 days. Now, let us discuss the treatment of other forms of meningitis other than bacterial meningitis we just discussed. Viral meningitis are usually self-limiting. Treatment is supportive, antipyretics for fever, anticonvulsant for seizure, and so on. However, it's important we add intravenous acyclovir until we are able to rule out herpes simplex and varicella zoster. Recovery is 7 to 10 days. Tuberculous meningitis, you use the usual regimen of rifampicin, isoniazid, pyrazinamide, and ethambutol with a steroid. Duration is 9 to 12 months. Cryptococcal meningitis, you treat with amphotericin B plus flucytosine and follow with fluconazole for maintenance. Duration is usually above 6 months and can last up to 12 months. For non-infectious meningitis, you manage or you treat the underlying cause, SLE, malignancy. So whatever is the underlying cause, you manage and treat such underlying cause. Now let's turn to prevention. This is a vital but often overlooked aspect in the management of meningitis. So we'll talk about vaccination. There are vaccines that helps to prevent meningitis. We have the Haemophilus influenzae type B vaccine, the pneumococcal vaccine, and the meningococcal vaccine. Then you can have chemoprophylaxis. This is important for close contact of patients with meningococcal infection. Rifampicin or ciprofloxacin within 24 hours of exposure is ideal. Then we have public health measures or other general measures like hand hygiene, isolation of infectious cases, especially if it's from meningococcal infection, outbreak control, and prompt treatment of ear, nose, and throat infections. What is the prognosis? We'll talk about the mortality rates. For bacterial meningitis, mortality rates is about 10 to 30%. It's usually highest with Streptococcus pneumoniae. For tuberculous meningitis, 20 to 50% mortality rate. For viral meningitis, they usually have good prognosis with supportive care. Mortality rate is actually less than 1%. What are the poor prognostic indicators in meningitis? Extremes of ages, low Glasgow Coma score, delay in initiating antibiotics, presence of seizure, strep pneumoniae infection itself, it's a poor prognostic indicator, immune suppression, focal neurologic deficit, septic shock, and the presence of a rapidly developing rash, which could indicate meningococcal infection. Early diagnosis and treatment significantly helps to improve outcome in meningitis. Now, a case challenge for you. A 28-year-old male presents with a 2-day history of headache, fever, and neck stiffness. Lumbar puncture was done, and cerebrospinal fluid shows WBC count of 1,200 per microliter, and 90% of them are polymorphonuclear cells. Glucose of 20 milligrams per deciliter, and protein of 180 milligrams per deciliter. The gram stain reveals gram-positive diplococci. The questions for you are: 1. What is the most likely pathogen? 2. What are the immediate management steps? And 3. What is the role of steroids in the management of this case? Kindly provide your answers in the comments. To round up, let's take some key takeaway. Meningitis is the inflammation of the meninges and subarachnoid space. It is a medical emergency that requires prompt diagnosis and treatment. Suspect meningitis early. Don't have to wait for the complete triad. Lumbar puncture and CSF analysis is the cornerstone of diagnosis. Start empiric antibiotics immediately. Don't wait for lumbar puncture results or even blood culture results. Base empiric antibiotics on age, immunity, as well as the risk. Give early dexamethasone. As soon as culture results are available, you tailor antibiotics based on culture and sensitivity. Prevention through vaccination and prophylaxis are key to reducing the burden of the disease. Thank you for staying with me through this overview of meningitis on ClinMed Compass. Always remember that in meningitis, every minute counts. Your prompt action determines the patient's outcome. If you found this lecture helpful, please like this video, share it with your colleagues, and subscribe for more high-yield internal medicine content. Don't forget to tap the notification bell so you never miss an update. Until next time, I am Dr. Emorinken. Stay curious, stay passionate, and keep learning. Goodbye.